Good evening, ladies and gentlemen, to all our colleagues. Thank you so very much for joining us for another Thursday edition of the Clinix presented webinars. And this week we have a special presenter, a special guest. It's a colleague, and he should be everybody's friend, Dr. Ali Morudu, who is practicing obstetrics and gynecology at Clinix Tepo Hospital out in Soweto, and also at GM uh, Day Hospital out in Johannesburg. So we will share a few more words about Dr. Morudu so you can get to know him for those of you that don't, and I'll give you some more information on that. Just a number of house rules and also some guidance for those who joined the webinar tonight and expecting CPD points. The webinar sessions that we host on a Thursday are all accredited for CPD points, and they are all accredited. So I would just like to encourage all those who did not physically register and only received the link from a colleague who had registered. The colleague will receive the CPD points. So please make sure that you also click the link that allows you to register, and you will personally receive your own CPD points for attending tonight's webinar. If there are any queries or anybody has any difficulties, please feel free to write to our colleagues who are part of the Clinix presentation here tonight in the background at webinar at Clinix, and we are able to assist you to make sure that you receive your points. And generally, those are quickly issued to us through the HPCSA, who has a new portal and a new way of allowing us to facilitate these evening sessions. What I'm going to do is perhaps just for those of you that don't know me, my name is Dr. Burton Shinners, and I'm the Chief Medical Officer at Clinix Health Group. And in the background, for the people that are actually more effective than I am, it's Sam and Tolakele, and they are assisting to make sure that everything works efficiently, smoothly in the background. So what I'm going to ask while Dr. Marudu is presenting, if you could please hold your questions till later. Those are the verbal questions. But in the group, in the chat rather, feel free to submit any questions that you may have, and feel free to encourage him and applaud. I'm sure he's going to get many of those. It's the nature of Dr. Marudu. So please feel free to do that. We will read all those questions towards the end. And those of you that would like to speak and ask your questions directly, please put up your hand towards the end of the presentation at the Q&A session, and we will then unmute your mic, and you will be able to ask those questions directly. Just as a reminder, just so you know, for next week, and I will announce it again towards the end of tonight's session, we are going to have another presentation next week, and that is going to be presented by Professor Koto. Professor Koto, you all know quite well, and so he's always quite popular as far as these webinar presentations are concerned. Professor Koto's subject matter is sepsis on the edge and turning the tide in abdominal catastrophes. And Professor Koto is a big proponent and supporter of endoscopic surgery and methodologies when it comes to performing any form of abdominal surgery. And Professor Morudu, it's coming. Dr. Morudu is not far from professorship, no doubt, and he himself is quite a supporter of endoscopic surgery. So just some information and background on our speaker this evening. Dr. Morudu is a gentleman. For those of you who get to know him, he's a wonderful human being, and no doubt somebody that many patients tend to gravitate towards. He's a specialist obstetrician, gynecologist, again at Sepotemba Clinix Hospital out there in Soweto, also at Clinix Dr. GM Day Hospital in Johannesburg itself. He's a fellow in reproductive medicine and endocrinology at the Steve Biko Academic Hospital, University of Pretoria. He's a fellow and a diplomat of the College of Obstetricians and Gynecology, and he holds a master's degree in Obs and Gynae from WITS. And he also holds a master's degree in the biotechnology of human-assisted reproduction and embryology from the University of Valencia. He has completed numerous courses at the Minimal Invasive Surgery Academy, headed by Professor Arno Wadis in Dubai. This is a Master of Laparoscopic Surgery in Gynecology, Master of Science of Anatomical Landmarks, Master of Surgical Management of Deep Endometriosis, and a Master of Hysteroscopic Surgery in Gynecology. He is a passionate physician when it comes to endoscopic and reproductive health that basically began during his earlier registrar days at WITS. Dr. Morudu, we really looked forward to hearing your presentation this evening, and I know everybody's in for a big treat from your insightful presentation we've been eagerly waiting for. Yeah, we wish you every success. We'll be right here, and we look forward to getting to know you much better during the course of tonight. Thanks, Dr. Morudu.
Thank you very much, Barton, for the kind words. Um, as I've just requested that if I may keep my camera off during the presentation, and then I'll switch it on as soon as it's time for the Q&A. So when I was invited to give a talk, I had to take some time to think about what I'm going to talk about, and given that these webinars are mainly for quite a diverse group of clinicians. So it's never an easy fit to try and get a topic that speaks to everyone. And I therefore thought that maybe I should discuss something that is not quite common, but yet very important, because um, not that only this patient present to gynecologists, but these patients are mostly seen by all of us. And sometimes if we do not or are not aware of this condition, it has quite devastating effects, especially on women and their health in general. So I'm hoping that you will be able to pick something out from today's talk, and that it might be helpful. So my talk, as is stated there, is premature ovarian insufficiency, what we call POI. And if you look at the image on the screen currently, it just shows you what a schematic or a picture of a normal ovary would appear like, and what a picture of a patient who has primary ovarian insufficiency looks like. So basically, POI, which I'm going to refer to during the course of this presentation, is a clinical condition where there is loss of ovarian function. It's characterized by loss of ovarian function. And in majority of women, it will present as amenorrhea, oligomenorrhea, or even irregular menses. That is lasting for more than 4 to 6 months. And this is also characterized by the fact that you have an increased level of serum gonadotropins with decreased level of estradiol. And it's mainly defined in women that are less than 40 years of age, and can also manifest as either primary or secondary amenorrhea. And its prevalence is about 4 in 100 women, which is about 3.7%. As you can see, 4 in 100 is quite a significant number. So let's look a bit at the terminology in terms of how do we differentiate these terms. POI is mainly a cessation of menses before the age of 40, whereas early menopause is when menses cease between the age of 40 to 45. And what we call your usual age of menopause is when menopause ceases between the age, menses cease between the age of 45 to 50. And if it ceases over the age of 50, this we term late menopause. And the other important thing that I would like to bring to your attention is to distinguish between what we call DOR and POI. DOR is basically diminished ovarian reserve. So with diminished ovarian reserve is often associated with regular menses. So these women, they have diminished reserves, but they would still be having regular menses. And in our terms, in the field of reproductive medicine, we say that women that present with diminished ovarian reserve are at risk of poor ovarian response. And this is mainly where when we do controlled ovarian stimulation. Once we see a woman that has a diminished ovarian reserve, we know that the likelihood of doing a successful ovarian stimulation is very low. Therefore, we characterize them as poor ovarian responders. But both these conditions lie mainly in the same spectrum, that's POI and diminished ovarian reserve. However, women who present with POI, they face more challenges which are wider than just being a fertility thing on its own. And therefore, it's important that we do pick them up so that we can manage them appropriately. So let's looking at the sequel of this premature ovarian insufficiency. The significance mainly lies in the consequences, which not only affects fertility but also impacts on the woman's overall health, including bone health, cardiovascular health, neurological function. And when all these systems are affected, there is a long-term consequence, as POI and early menopause are also associated with higher mortality rates and reduced life expectancy. It is also associated with comorbidities such as autoimmune diseases, where cancer treatment also is another factor, especially in those women that receive what we call risk reduction surgery, especially with your BSO or bilateral salpingo oophorectomy. In those women that we deem that they are at high risk of cancer. And once they have that BSO, they are largely at a higher or greater risk of mortality. In terms of the main symptoms of premature ovarian insufficiency, most of the symptoms are mainly due to the hypoestrogenism, the low estrogen that they face. And this will in turn result in menopausal symptoms, which we all know are associated with a reduced quality of life. And then in the non-iatrogenic POI, what we term idiopathic POI, typically the onset of the symptoms will be gradual and they will have this prolonged fluctuating course as compared to the profound estrogen deficiency that we may see in those that have what we call surgical menopause, which is quite a rapid drop or profound drop in the estrogen levels. And then with regards to life expectancy, we have multiple cohort studies that have confirmed that in those women who get a bilateral salpingo oophorectomy early in life or at a younger age, it is more associated with an increased overall mortality, and that the number needed to harm is 71, meaning that for every 71 patients that get a BSO, there will be one additional death. That's why it makes this condition quite a devastating one. And this will be death within the 20 years in the follow-up group. And then the risk of mortality was higher for those women who did not receive any hormone replacement therapy after a BSO, or those who did, or as compared to those who did. So in women that never had any HRT, the risk of death was higher if you compare them to those that received HRT. And then the higher risk of all causes of mortality or cardiovascular mortality after BSO before the age of 40 has been reported. Hence, it is recommended that patients with premature ovarian insufficiency should be informed that without HRT, there is a great association to reduce life expectancy and that they should be offered HRT until the usual age of menopause to reduce that risk of morbidity and mortality. Whether they exhibit estrogen deficiency symptoms or not. So hence it is quite important to identify them because majority of them might not even present with symptoms and yet they would require attention and HRT. In terms of risk factors, identifying these risk factors for POI is quite crucial and as it may allow for preventative measures to be implemented. And the predictors of POI are majority of them are X-linked chromosomal abnormalities, and majority of multiple studies have identified a family history as well as a strong predictor of the age of menopause, and the odds of an early menopause have been found to be increased in women with family history of early menopause, with studies showing that patients with a first degree relative with a premature ovarian insufficiency have an 18-fold risk of POI, whereas second degree relatives will have a 4-time increased risk, and a third degree relative will have twice the risk. And in terms of infections such as mumps sulfuritis have a causative role in premature ovarian insufficiency, whereas TB and HIV have been associated with it as well. Other risk factors would be your lifestyle factors such as smoking. They've all been shown to be associated with an early age of menopause. Women that have a lower BMI and a history of, and those women that have a history of pelvic surgery, surgeries such as for endometriosis, ovarian cystectomies, also have been found to be quite associated with that increased risk. Then other risk factors would be your chemical exposure to endocrine disruptors like heavy metals and organic pollutants. And then the ASHRAE guidelines therefore recommended that clinicians must make an effort to decrease the risk by screening those that are at risk, looking at these risk factors that I've just put there, and which may entail inquiring about symptoms of POI in patients that would present with menstrual disturbances and addressing modifiable risk factors such as lifestyle factors, such as smoking. And then also important to counsel these patients that at a greater risk based on the risk factors to also consider fertility preservation earlier rather than later on in life, as it might actually be required. Then in terms of the actual causes, as I've mentioned earlier, that this can either be spontaneous or what we call idiopathic or iatrogenic. And with idiopathic POI, the most common cause which accounts for about 70 to 90% of the cases. I mean, the idiopathic form is one of the most common one, which accounts for 70 to 90. And genetic causes can either be numerical or structural, and majority of these genetic causes being your X-linked chromosomal abnormalities, the most common one being Turner syndrome and triploidies, like 47XXY. And structural causes can be deletions, inversions, duplications, and translocations, with the commonest structural one being the FMR1 premutation, which results in Fragile X syndrome. And this also carries about a 20% risk of premature ovarian insufficiency. Autoimmune causes such as Addison's can also be preceded by POI, and autoimmune thyroid hormone disorders are also common in POI. And then with the iatrogenic forms, this include patients that receive chemotherapy, pelvic field radiotherapy, ovarian pathology, or pelvic surgery. And therefore, it should be noted, and we should be able to pick up all those at-risk patients. And there are studies, especially in breast cancer patients, that have revealed that the risk of POI is decreased if a woman receives treatment before the age of 40. So that is another thing that one needs to consider. And then in terms of chemotherapy, where there is an addition of taxanes to anthracyclines-based treatment, there will also be that increased. And all other gynecological cancers and other cancers such as your colon cancer, rectal, and anal cancers, which are commonly treated with pelvic radiation, can also induce premature ovarian insufficiency. And both surgery for endometriosis, endometriomas, or other ovarian pathologies such as your ovarian torsion seems to also have a huge influence at the age of menopause and therefore the risk of POI. And then in all those women that get bilateral salpingo-oophorectomy before the age of 40, we know that definitely they will develop premature ovarian failure. And therefore, the ASHRAE guideline group recommended as a good practice point that all healthcare professionals that will be performing any of these treatments on any of these patients should actually discuss the risk of premature ovarian failure with their patients. And this should form part of the consent process. As you are consenting these women for all of these procedures, you need to inform them that they are likely going to, or the risk of developing POI is quite high, and therefore they should be aware of the risk. Then, in terms of symptoms, the clinical presentation is quite variable, and it may also, or may likely, or may include secondary or primary amenorrhea. But what is important is that amenorrhea is not a requirement for the diagnosis of POI, although it will manifest in about 50% of women that have POI within a year of developing menstrual irregularities. And these menstrual irregularities may be followed by symptoms that are related to estrogen deficiency. And those that are attempting to conceive may present with primary or secondary infertility. And of note is that POI related symptoms may be transient or intermittent and can vary in severity, reflecting the fact that there's still that fluctuating ovarian activity, and that may occur after the onset of a non-iatrogenic or idiopathic POI. And then in some women with premature ovarian insufficiency may not experience symptoms at all, especially in those that are younger, in younger women who present with primary amenorrhea. They are less likely to tell you of any other symptoms that are related to estrogen deficiency, suggesting that the onset of symptoms is mainly due to estrogen withdrawal rather than estrogen deficiency. So they will be having deficiency, therefore they would not be exhibiting any of those symptoms that you'd expect, except for maybe amenorrhea that they might be presenting with. And then in those women that undergo surgical menopause, those ones they tend to experience a sudden decline in their estradiol levels rather than a gradual decline. And we know that with the retrospective data indicates that this is linked to a more severe menopausal symptoms. Hence, surgical menopause has more severe symptoms as opposed to the gradual one that you'd get with premature ovarian insufficiency. And this variability of symptoms has other clinical implications, as menses may return in up to 15% of women with non-surgical POI, and the risk of pregnancy, though very small, but is still there at less than 5%. Hence, in those women desiring fertility, those women that do not desire fertility, contraceptions should be offered. And then ESHRA recommends that all healthcare professionals must inquire about the symptoms of estrogen deficiency in women that are presenting with irregular menses or amenorrhea, and to also exclude the diagnosis of POI in women aged less than 40 years who have amenorrhea and irregular menses. We will get into the how one would go about diagnosing the condition. Now, this is just a flow diagram that kind of gives you an idea of how one would go about making the diagnosis. So basically, the diagnosis is confirmed in women who are less than 40 by a combination of a couple of things: a history of about 4 to 6 months period of disordered menses, including amenorrhea and irregular menses, in women that are not on any hormonal treatments, such as your combined oral contraceptives, injectables, and your long-acting reversible contraceptives. And a diagnosis is then confirmed by biochemical measurement of an elevated FSH, which is follicle stimulating hormone. And the second part of that diagnosis or the diagnostic workup is to try and establish what the cause of the premature ovarian insufficiency is. And other causes of amenorrhea, such as pregnancy, polycystic ovary disease, or polycystic ovary syndrome, thyroid disorders, hyperprolactinemia, should also be ruled out before a diagnosis of POI can be assigned. And in those that are currently or at that stage on contraceptive, we know that contraceptives as well can cause amenorrhea. And then, but in those women, the FSH levels are usually low, and some hormonal treatments, such as those contraceptives, might need to be stopped so that one can be able to confirm the diagnosis of POI. And in those women that have had surgery, particularly bilateral salpingo-oophorectomy before the age of 40, in this women, there's really no need for additional tests, as we would have basically identified what the cause is. So diagnostic testing is not necessary for these women, as we already are aware of what could have caused the POI. And then with FSH, currently FSH it's the gold standard test in establishing the diagnosis, and we use a cutoff of more than 25 international units per liter, and this is used to make the diagnosis. And the beauty of it is that it can be pulled or drawn randomly, so you do not necessarily have to wait for a certain period of your cycle to draw this FSH. And your estradiol alone should not necessarily be used to make the diagnosis. But if one finds levels that are lower than 50 picograms per mil or 183.6 picomoles per liter, it's indicative of a hypoestrogenic state that these women might find themselves in. And a second test then may be required if one finds that the first test was inconclusive. But usually, if the first test is conclusive, the result should be deemed diagnostic. And then in case of inconclusive tests, this then you can repeat this test in about 4 to 6 weeks to confirm it. Then the other thing that we mentioned is the anti-Mullerian hormone and whether it has a diagnostic value with POI. But in with regards to this anti-Mullerian hormone, the only difference is, or the only value that it has, is that it distinguishes those women that present with POI versus those ones that have PCOS or hypothalamic amenorrhea. In instance, in POI, the anti-Mullerian hormone levels will be low, whereas in PCOS, AMH will be high, and in the hypothalamic amenorrhea, the levels may be normal or mildly reduced. However, there is no evidence for any advantage of AMH over the current FSH-based diagnostic testing that we do, and hence it should not be used or preferred as your primary diagnostic test. So, as I've mentioned earlier, there's a quite a strong familial link to the risk of POI. And I just wanted to show the slide to just in terms of conscientizing that as much as you have a patient that is in front of you, one needs to understand that their family members, especially with idiopathic POI, are also at risk of POI, and therefore genetic, especially in those that have a genetic cause. If we look on my left side, in the general population, as discussed earlier, the risk is about 3.5, but if a patient has idiopathic POI in the family, their risk increases to about 15%. And therefore, you also want to get the family involved, and you would advise them to watch out for signs of POI like your menstrual irregularities and menopausal symptoms. And those that are using long-term contraceptives, you might want to ask them to at least seize them for a while to see if those contraceptives are not necessarily masking signs and symptoms of POI. And then they should also be advised on the prevention in terms of lifestyle modifications, like avoiding smoking and maintaining a normal body weight. And those that are not ready for families, they might need to be advised on fertility preservation as well as family planning, because once they get, if they are planning on starting families later on in life, you might find that already they have got that diminished ovarian reserve. And then, of course, genetic counseling as well is quite important for those patients. Now, let's discuss a bit about how now we are going to treat these patients. And most of the available literature, especially on puberty induction, is based on what we have seen with Turner syndrome, but other causes of premature ovarian insufficiency that require puberty induction, which include your DSDs like your congenital gonadal dysgenesis, ovotesticular dysgenesis, or mosaic forms of Turner syndrome, galactosemia, and those patients that have are childhood cancer survivors. And those they will require puberty induction. And the aim of this puberty induction is mainly to achieve further growth, especially in those young women, increase their bone mineral density, achieve an adult breast and uterine configuration, achieve monthly withdrawal bleeds, and also achieve an optimal neurocognitive development. And if in those that are diagnosed quite at or at birth, there is a bit of debate in terms of when to initiate growth hormone, but it has been stated that it should be started at 2 years or when their height falls below the fifth centile on the growth charts. And then in terms of estrogen therapy for puberty induction, it is quite the consensus is that it should be started or commenced at around the age of 11 to 12 years. And if there's no spontaneous development, and if they also have a high level of FSH. And of course, estrogen therapy can be started either transdermally, and the doses are there. And this should also be increased gradually over 6 to 12 months intervals over the period of, in 6 to 12 month intervals over a period of about 2 to 3 years. And then again, there should also be introduction of progesterone to mainly protect the uterus. And this should be done after 2 years of estrogen therapy, or if these patients develop breakthrough bleeding. And this can be given as an oral micronized progesterone of about 100 to 200 micrograms, or dihydrogesterone of about 5 to 10 milligram per day. And it can be started on and about day 12 to 15 of the cycle. Mine was a bit slow. And then how about POI and fertility? We know that loss of fertility is one of the key accompanying features, and these women should be informed that this diagnosis then therefore reduces their chances of natural fertility. And as mentioned earlier, those with non-surgical POI may still have that fluctuating ovarian activity with resumption of menses, and this chance is usually higher within the first year of the diagnosis. And the predictive factors for this resumption are markers of ovarian activity at diagnosis, family history, and secondary amenorrhea. Then women with lower FSH levels at diagnosis or at the initial evaluation, and those who are younger at diagnosis and with secondary amenorrhea, those are the ones that you would know that likelihood is that they would still have those fluctuating levels. And radiotherapy may induce structural and functional changes to the uterus, especially in those women that receives over 5 grays. And this can also adversely affect implantation and maintenance of pregnancy. And it also increases the risk of placental attachment disorders like the placenta accretor spectrum. And therefore, importantly, with women with POI should be informed that there's no interventions that have been shown or reliably shown to increase ovarian activity and natural conception rates. And in this regard, therefore, oocyte donation is one of the most successful treatments that we have, that is established for any of these women that would require fertility. And in those women that have non-iatrogenic POI that are considering oocyte donation, one needs to be aware that if they are or want to use oocytes from a sibling like a sister, they should be informed that there is that risk of a shared genetic risk of POI and diminished ovarian reserve, and it carries a risk that one or there might be a need of ovarian stimulation cycle cancellation. So they need to be aware of that, as we know that with ART, the cost is one of the biggest drivers, and therefore picking the right type of donor is one of the most important steps to making sure that one achieves success. And in those that are just at risk, preservation can be considered, especially those women that are undergoing any form of treatment, chemo or radiation, all of that. They should be advised, and we advise that they need to be offered fertility preservation, especially if they desire fertility. As we know that once they go through those treatments, the risk of the premature ovarian failure is high. And those that have an established POI, there is complete or near complete exhaustion of their follicular pools, and therefore fertility preservation interventions are therefore not recommended. So those that have already have that established one, really there's not much that one can do further. Then what about pregnancy outcomes? Pregnancy-related risks are mostly associated with the actual costs of the POI, and to some extent the pregnancy is or whether the pregnancy is natural or if it's an oocyte donation pregnancy. And the risk of miscarriage, unemployment rates are the same in pregnancies after idiopathic POI, and in all other women that have normal ovarian function. And then women with previously treated cancer had a higher risk of adverse pregnancy outcomes such as PPH or postpartum hemorrhage, operative or assisted deliveries, as well as preterm birth. And then the treatment of cancer is also not necessarily associated with an increased risk of congenital or chromosomal abnormalities. However, the stillborn or early neonatal death rates are not increased as well, especially if one adjusts for prematurity. The risk is not necessarily increased in these women. And again, important to know that chemotherapeutic agents such as your anthracyclines and high dose of cyclophosphamide, as well as high dose of mediastinal radiation, are associated with cardiomyopathy and heart failure, which can affect their ability to carry a pregnancy. So therefore, these women need to be assessed, especially if they've had chemo or radiation previously. And then with oocyte donation pregnancies, regardless of the age of the recipient, there is an associated risk of pregnancy-induced hypertensive disorders, and the risk of threatened miscarriages and cesarean deliveries. And those women that should therefore be offered some low-dose aspirin, particularly to reduce that risk of pregnancy-induced hypertension, like your preeclampsia. Now, what should we be doing for these women preconception? So with these women should be obviously offered preconception care, which would usually entail immunization for rubella, varicella, measles. We should be optimizing their BMI, and we should treat and optimize all coexisting medical conditions that they might have. They should be offered folic acid supplementation, addressing lifestyle factors such as smoking. And then management should entail a multidisciplinary team, which would include a cardiologist, a fetal maternal specialist, and an oncological assessment should also be done, especially in those women with POI after treatment of cancer. And then in terms of pregnancy investigation, tests to assess endocrinopathies should be done, especially those associated with autoimmune POI, such as your thyroid function test is also advised. And we should also measure their resting BPs, and they should also receive echo, especially in those that had received cardiotoxic treatments, such as those with prior treatment with atrocyclines, high-dose cyclophosphamide, as I've mentioned, and mediastinal radiation, either of the chest wall or of the breast. And then important again is to note that in women who have Turner syndrome, they should have a measurement at echo of the ascending aortic size index, and if this measurement is over 2.5 by X-ray, and ASRM suggests over 2 centimeters, and therefore they should be discouraged to fall pregnant, as this carries a risk of further dilatation and can lead to aortic dissection as well. Then how about the impact of POI on our musculoskeletal health? We know that there's a higher risk of osteoporosis, and it should be identified and therefore addressed, especially at the diagnosis of POI. So usually when you diagnose these women with POI, and depending on how long they've been having it, it's always important to have a baseline DEXA scan, and they should also have ongoing DEXA scans to try and see how the treatment either is working, or if they are deteriorating from whatever level they were when you first did the baseline one. And we know that Z scores are used to define a low bone mass, whereas your T scores will be defining osteoporosis. And in terms of management, lifestyle modification, which again entails weight-bearing exercises, avoidance of smoking, maintenance of a normal BMI, a balanced diet with a recommended intake of vitamin D and calcium, and also avoiding excessive alcohol should also be emphasized. And then when with hormone therapy, it is recommended that for these women to maintain bone mineral density and to prevent osteoporosis, they should be offered oral estradiol, and that should not be at a level of less than 2 milligram, or a transdermal estradiol of about 100 micrograms to optimize this bone mineral density. And if COCs are used, one should recommend that these women should be on a continuous or an extended use as opposed to sequential to maintain the integrity of that bone mineral density. And then with regards to monitoring, it's really unclear as to when does one repeat a DEXA scan, and therefore when your bone mineral density was normal when you do the baseline treatment, and if the woman is on adequate systemic HRT, there's really no defined value in literature that suggests that repeating the DEXA scan within the 5 years of the previous one adds any value. But in those that have been found, so your BMD can be reassessed within about 1 to 3 years on those individuals with based on individual risk factors, and with those women who have been found on that baseline scan that you've done to be osteoporotic, and those that had a low bone mineral density. So those are the ones that one would consider repeating in within the 5 years, in 1 to 3 years of the previous DEXA that was done. Then in terms of your cardiometabolic health, women with POI or early menopause or iatrogenic menopause are, as we know, are at higher risk of cardiovascular disease and death. And this is probably due to the fact that they tend to have a shorter exposure to the cardioprotective effect that we tend to have with your endogenous estrogen. Therefore, that's why they have this this increased risk of cardiovascular disease. And they are also at higher risk of hypertensive disorders, diabetes mellitus, and hyperlipidemia and endothelial dysfunction, which can also contribute to premature atherosclerosis. And therefore, they should then be advised that there is that increased risk. And this risk of cardiovascular disease also includes the risk of coronary artery diseases, stroke, heart failure, as well as increased cardiovascular mortality. And this is regardless of what the cause of the ovarian insufficiency is. And therefore, also very important that they should be managed effectively. Lifestyle modification, annual screening should be performed, and they should stick to a healthy diet, avoid smoking, alcohol, and also exercise. And with your HRT up to the age of usual menopause. Oh, sorry, I think my slides were stuck. If I may just revert to the slide. This is the slide that I was just discussing now. And I'll move to the next slide. So the other important thing that we need to recognize is the fact that there is an impact on neurological function and quality of life. And there is that risk of cognitive impairment and devastatingly dementia as well. And hence, the detrimental effect of bilateral salpingo-oophorectomy on cognition and other neurological disease should be discussed, especially with those patients that are planning it before the age of 45. And HRT is recommended. And again, we continue with it until the usual age of menopause. And we know that this then reduces the risk of cognitive impairment and the risk of dementia, even in the absence of menopausal symptoms. So as I'm trying to emphasize the fact that menopausal symptoms alone shouldn't be your guide in terms of deciding whether to screen this patient, to diagnose them, and to treat, because the sequelae is quite devastating. And we know that it also has this significant impact on psychological health and the quality of life. And therefore, what is suggested by ESHRE is that as healthcare professionals, we should try and be uh, uh, and be compassionate and sensitive about this diagnosis. And what is recommended, which we use most of the time in when we give we are breaking bad news, is that we approach it with the spikes approach, where a setting should be fine. There should be a perception in terms of what the patient perceives of the condition. Invitation, we need to know how much they would like to know, and also be empathetic. And also important to the important part of the spikes is that strategy and summary is mainly to summarize the main points of the consultation and allow an opportunity for questions of clarity or whatever, and also to reinforce the plan. Because sometimes what we see is that patients come in, you give them the bad news, but we do not give them a definitive plan of the next steps that needs to be taken, and then they are lost to follow up. So applying that spikes approach kind of gives you steps that if you follow, then you are unlikely going to lose this patient at any point. Then, in terms of management, we know that the mainstay of management, as I've discussed earlier, is hormone replacement. And this also includes HRT or combined oral contraceptive. The principle is similar to those women that have reached menopause, and the aim is mainly to try and approximate the physiological replacement requirements of these women. And if they have a uterus, one should combine both therapies, estrogen and progesterone. And non-oral, we know that non-oral deliveries of estrogen avoids that first pass effect, and thereby preventing or the risk of thrombotic events. And the other thing that is important is that the the difference between premature ovarian insufficiency and your usual menopause is that these women tend to require doses that are higher, and if you give higher estrogen doses, you should also give higher progesterone doses to protect the endometrium from the effect of the mitotic effect of estrogen. And hormone replacement is offered, again, I'm emphasizing, even in the absence of estrogen deficiency symptoms. As I've said, in younger women, they might not exhibit any of those symptoms. So one should still offer that treatment. And then indications mainly are related to the sequelae that I've mentioned, vasomotor symptoms, genitourinary symptoms, the life expectancy, musculoskeletal health, cardiovascular health, and the quality of life and sexual function. And again, the aim is primary prevention of all of those conditions that I've just mentioned, which are mainly associated with morbidity and mortality. And again, what is of importance is that we need to advise these women that HRT does not necessarily provide contraceptive. As I've said, there could be this fluctuating ovarian activity. And then in those that are not desiring pregnancy, HRT remains unchanged and do not those that desire fertility, you can continue with HRT. It does not really impact the chance of natural conception, and sequential HRT regimes is therefore recommended. And those that require or are not desiring fertility, they should be offered contraceptive in the form of COC and continuous regimes to avoid estrogen deficiency occurring during that pill-free period. So if you are giving COC, make sure that they are on uh, um, continuous regime as opposed to sequential. And of course, transdermal or oral estradiol alone, those other women then can also be put on a levonorgestrel intrauterine system. And I'm almost getting there in terms of monitoring. I just put this slide so that we just follow. So at the diagnosis, hormone replacement is then commenced, and one is to provide information of risk factors that can be modified either through lifestyle, behavioral change, including all of those that I've mentioned: smoking, healthy eating, physical activity. And in terms of monitoring, annually they should be seen. And this is to make sure that there is great or good adherence to therapy, to assess their bone health risk factors, cardiovascular risk factors, blood pressure, weight, and smoking status, their psychological health and quality of life, any estrogen deficiency symptoms, including your genitourinary symptoms, sexual health, and other concerns. And less frequently, as I've mentioned, your bone mineral density in the form of DEXAs. Those will be done if indicated, as I've mentioned. Screening for diabetes and hyperlipidemia. And of course, and other further tests are based on mainly on anything if it's indicated. And other things that one should look for is those other risk of osteoporosis and bone mineral density. And again, then you continue this HRT until the usual age of menopause, and then deciding on whether to continue will then depend on personalized risk factors. This is that I've spoken about in a single slide, and I'm not going to go through it. But if anyone needs to share, I can share it. It's published in one of the ASHRAE guidelines that are the latest guidelines that we published. And it just kind of gives you a flow as to what to do when and what to advise women and what can be added. As you can see on that slide, there's also non-hormonal treatments, which I haven't went into full discussion given the time constraints and how to treat each and every other individual causes or risks that are associated with this. But if you haven't had anything from this talk today, what I want to emphasize is the fact that as we are all seeing women at some points in our practices, it's quite important to ask about some of the symptoms, as some women might not be aware. And as we have seen, it has a really devastating effect, and it causes unexpected early deaths. And if we do not screen and diagnose these women, we are likely failing them, as they are likely going to die younger than they should be dying. And therefore, we should be very, very vigilant, especially when we are dealing with these women. Don't just treat the symptoms, but look at them holistically and try and manage the sequelae and prevent future risks of problems in these women. Thank you. I think that should be the end of my presentation.
Excellent, Dr. Morudu. Thank you so much. Thank you so much for doing that. And I told you beforehand, everybody was excited to hear from you and that you're going to be exceptional with your presentation. So yeah, you did not disappoint. Thank you. It was so comprehensive, so much insight. And you said you wanted to cover a topic that would cover the disciplines across the medical practice and the medical fraternity. So thank you so very much. Everybody's applauding you. I hope you can see that. Please feel free to put on your screen. You said you'll come back on towards the end, so you and I can do the question answer session together, please.
Yeah, back
Yeah.
to
Dear colleagues, ladies and gentlemen, for those of you that did not join early on when you started, I just wanted to say welcome to each and every one of you, and thank you for joining us at this Clinix Health Group webinar, which is presented every Thursday. While the questions are coming in, there are quite a few that have been steadily streaming in, Dr. Morudu. I just want to give you a teaser for the next 2 weeks for presentations that will be held here at this webinar. In 2 weeks' time, on the 19th, there's a topic that will be presented by two medical law and malpractice litigation attorneys, and we'll also cover professional indemnity litigation for doctors, and then also obviously from a private hospital point of view. The topic they'll be covering is an overview of civil litigation, South Africa's current litigation landscape, and case studies on medical negligence cases. So they'll be presenting some of those, and then next week, Professor Koto, who you all know quite well, no doubt. He will be presenting Sepsis on the Edge, Turning the Tide in Abdominal Catastrophes. So he will be presenting on that topic next week, Thursday. Again, Dr. Morudu, don't see you on the screen yet, but I know you're there. Yeah, there are quite a few questions for you, and maybe you can share some insights from your perspective and at your point of view. Um, I know there's a question here. I'm just gonna read it directly, right? But it's not me. So it says, I'm 41
Sorry,
years
Dr.
old.
Shinas, I just received a call from the labor ward, but it's fine. We can continue.
Of course. I'm 41 years old, and the last time I had periods was 6 months ago. What are my chances of having another child? You understand, I'm reading from the questions here on the screen, right? It's not me.
41-year-old,
Yes.
period six
The
months
last
ago.
time I had 6 months ago, yes.
I'm an optimist, so I wouldn't necessarily say the chances are low until we really assess the patient and see what we are dealing with. Again, it's a difficult question to answer, especially if you don't have the full context in terms of other factors that might play a role. So my advice would be see a gynecologist and let's take it step by step and we can then decide. Having a child can happen. Remember, we have discussed oocyte donation, so not necessarily everyone can have a child through autologous oocytes, but there's opportunities in terms of oocyte donation. So having a child is always a possibility, even if you are over 40.
Yeah, and so following on that, Silima Loka is asking, how is oocyte donation done?
So, oocyte donation basically what we do is um, in women that have diminished ovarian reserve, still have a uterus that can, a functional uterus, they can identify a donor either by their own or through some clinics which have oocyte donation programs where basically a woman that still has good reserves will then be stimulated. Then oocytes are then retrieved from that woman, and depending on whether the patient has a partner or using donor sperm, then those oocytes will be fertilized with the partner sperm, and then the transfer will be then done in the recipient, which is the actual woman that receiving the donation. And basically for the recipient is mainly just making sure that we prepare the uterus for the embryo transfer. That's in a nutshell.
In a nutshell. Yeah, I know that Professor Duplessis has a question around statistics and the incident rate of the presentation of what you discussed tonight. So, Professor, if you feel you would like to ask the question directly, feel free to put up your hand and we'll unmute you. Thank you. And then we've got a question from Professor Yasmin
I'm
Adam.
not sure if your line is failing with
Is this me, Dr. Morudu?
no, no, your line was breaking a bit, so I was not sure if it's my network or yours.
I was telling somebody on the line that it was not yours. But Professor Adam is also with us tonight, and she says, thank you for a great talk, and is asking for some elaboration on the mechanism of ovarian failure or insufficiency in women living with HIV.
Mm,
To repeat that?
I think, thank you, Prof. Adam, for the great question. I'm not, HIV on its own is not necessarily a causative factor for ovarian failure, but it has an association. And usually it would be either associated with other conditions that can affect the pelvis, where your a risk of PIDs and TB and all of those other causes. they have an associated risk, but not necessarily a causative risk. I'm not sure if I've answered the question.
Yeah, the
Or
professor.
maybe if you can assist Professor Adam.
Yeah, we could, if you put up your hand, Professor Adam, we'll gladly unmute you and you can participate. Sam and Tolakela are standing by. Thank you. Just while that is being done, the question here about the incidence of what you discussed tonight is, it says surprisingly high. And so is there any information on the incidence at age?
But your line tends to break quite a bit. I'm not sure.
Okay, so the incidence of at age 13, 14, 15, for the majority of individuals who only pick up and become aware of their problem later, are there any incidences or information around it occurring much earlier in childhood?
I didn't get the gist of the question because your line was breaking a bit. So if you may kindly repeat the question.
Okay, I'm going to try again. Otherwise, if it's difficult, I'll ask one of my colleagues to step in. So what I'm trying to get at is with regards to teenagers. So at the age of around 13, 14, 15 years old, what is the incidence like for being diagnosed with the condition?
Usually in most of the teenagers, as I've mentioned, these are the patients that tend to present with those X-linked disorders that I've spoken about, Turner syndrome and your gonadal dysgenesis and all of those other conditions. And majority of them, as we see them in the endocrine clinic, is that they tend to present very as teenagers around that age of we say around 15, 16 to even some present at age 20. And majority of the time, their main complaint would usually be that primary amenorrhea that they experience. And unfortunately, it's where we tend to pick most of them up because then parents start getting worried when they don't see menses and that's the time that they usually present. I'm not sure if 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 that
Yeah,
answers
it's
the
okay.
question.
Professor Dirk's hand is up, so I'm sure he'll answer and ask directly. Thank you. Thanks, Sam.
Hi there. I hope you can hear me well. But anyway,
And yeah,
point I
Can
wanted to
you-
make was that I found your incidence that you described there as quite high. 3.7% is a very high number for me. And now the information of 3.7%, is that based on first world data? That's the one question. And the other part is, in the younger population, do we actually have any real numbers on what the incidence is then? Because there's a caveat to that. Is there actually environmental factors and other aspects that makes someone become vulnerable to this sort of issue? In other words, what happens over between the age of 10 and 30? Because I suspect that most of the women will actually rock up with this sort of problem after the age of 30.
yes, yes. Yeah, yeah. First part of the question, yes, most of the data is based on the Western data that we have. The South African incidence, we do not really have the numbers. And in terms of the the incidence, it's mainly incident that is based on I think it also included the iatrogenic numbers, hence it's slightly higher. Um, I'm not sure the second part of the question was that could there be any environmental factors? Possibly, yes, but we really don't have data that says if you live in such and such an area, or if you're exposed to such and such from the environment, you are more likely to have premature ovarian insufficiency. So that data is currently not available at this stage. We just know that it's mostly those chromosomal abnormalities, and it's familial and all of that. But in terms of direct environmental causes, we don't really have very strong data on that at this stage.
Okay. Oh, well, thanks. Just wondered. I know it's a problem because you're not going to have routine testing on teenagers, try to find it. So it's a bit of a problem to figure out what might be involved in creating the scenario.
Mm.
But thanks.
Thank you, Dr.
Thank you.
Dr. Mashilo. Thank you. Please go ahead.
Yes, thank you, Doc. Am I audible? Can you hear me?
You are clear. Thank you.
Yes, a good question on HIV. A quick cut. I wanted to ask if there are any changes in the prognosis of the concurrence of HIV and POI, and versus when the patient is having POI alone. Is there a way that we can weigh them differently? Thank you.
I don't think HIV on its own with POI has any significant impact. But again, if the fact that there's hypoestrogenism, it's one of the most impactful challenges with this thing, and therefore, if in those that are treated with HRT, whether HIV positive or negative, there's really no difference in terms of of the cause of the disease. So HIV is not necessarily or does not necessarily have a direct impact. Again, most of this data as well, there is more Western data. Until maybe we do our own local studies, where as much as we know that in the sub-Saharan Africa, that's where the most prevalence of HIV is, to actually see is there any difference in our women when you compare them to this data that we get from mostly the West. So I think it's one of the areas that we should in future look at, and hopefully we'll find those answers.
Yeah. Are you able to talk about the side effects of HRT?
Side effects of HRT.
Yeah.
I'm not really sure in terms of uh, general side effects. Could be quite
Yeah.
it could be quite a lot. I know there is quite concern when it comes to HRT, especially the risk associated with breast cancer.
Breast cancer, yes.
But we know that the current data that's coming out, it's showing us that the data was not really, and this was from the Million Women study a few years ago, where there was this hype that there is a risk of breast cancer, and now there's quite good data that's coming out of the of America, where they took basically all those women who are on their national health register, the medical insurance thingy. So these women were taking they were registered for HRT as chronic meds on their Medicaid thing, and they are looking at that data now, and it shows that the risk of breast cancer is not necessarily increased in those women because this is long-term data. So that risk is as much as there is a risk in those that are exposed, but it does not necessarily imply risk for the general population. And again, a risk of a thrombosis as well. It depends again on the condition of the patient. What do they have? BMI, other comorbid factors, and all of that. So HRT, I could safely say is generally safe in the general population, but again, treatment should be individualized to patients. As you have seen in the final slide that I've presented, I said commence once you make the diagnosis, then commence HRT if not contraindicated. And again, it's all about stratifying your patient's risk and making sure that one chooses the right course for them. But it's not generally just to say that HRT is bad, therefore women shouldn't be on it.
Okay. Yeah, because there was a associated question around HRT and
You are mute. I can't hear you anymore.
Dr. Shinas,
yeah.
yeah, we can hear you. Ladies and gentlemen, let's just give him a minute. He should be back.
Just to make him aware, earlier on when I took that call, it was the labor ward. There's, I think I've got about 6 minutes to go. I will probably need to attend to that patient sooner.
Hi, everybody. Dr. Shinas is having connection issues, but I think we had gotten to most of our questions. If you require the presentation, of course, Dr. Morudu, with your permission, we can share the presentation with you. Just email us at webinars@clinix.co.za. Dr. Morudu, thank you so much. It was a lovely presentation, and I think there were so many people clapping for you. This was really a fruitful webinar. Tolagere should be in touch with you in the next coming few days, just to give you a token of appreciation for all your efforts. And to everybody, please don't forget to join in with the next webinar that is coming up next week, Thursday. The link will be out, so just just register and then we take it from there. Thank you.
Thank you, Sam. Thank you, Dr. Morudu.
Thank you very much, Dr. Shinas.
Have a good evening. Thank you.
Okay, see you around.
See you tomorrow.
Bye.
Bye. Good night, everyone.